Good morning, everybody. Welcome to this webinar with Dr. Alecsandru Ionescu from Romania. The topic today is digital guided flapless implantology, main treatment options after the pandemic. I think this is a very hot topic. My name is Holger Kast. I am the moderator of this webinar today. And we're looking forward for an interesting 1 hour webinar with Alex Ionescu. Before I give the word to Alex, I would like to introduce you a little bit to the rules of this webinar. We have on the right side, you have your toolbar. And in this toolbar, you can ask questions. And so during the presentation, if you have questions, you can write them into the question field there, and I'm going to moderate those questions to Alex during the webinar. And even on the end of this presentation, we have a question and answer time. So we're going to try to translate or pass all the questions to Alex during this webinar. Before I give the word to Alex, I would like to tell a little story how Alex and TRI met. And this is because of our tissue level implant, which you can see here now on your screens. This is our tissue level. It's a unique tissue level implant, which has a pink color anodizing, which leads to a very high aesthetic tissue level implant. And as I know from Alex, he is using for 100%, he's a 100% tissue level implant user. And as you can see here, this is scientifically proven that this pink anodized color of the polished neck of the tissue level implant has a significantly influence on a higher aesthetic, especially in aesthetic zones. If you have a thin tissue layer, it doesn't shine. The titanium color of a normal tissue level implant doesn't shine through the tissue and gives you this gray dark tissue color. So that's why I think our tissue level implant is very unique, and it's great that Alex was one of the first dentists which used this tissue level implant, this TRI tissue level implants some years ago. And that's great. I think Alex is going to explain a little bit about this unique tissue level in his presentation. And now it's already on the time to pass the word to Alex. Please introduce yourself, and I'll give you the rights that you can start with your presentation. 1 second. And please go ahead, Alex, and start your presentation. 1 second here. Okay, let's go.
Good morning. Good morning in Europe. Just a second to start from the beginning. First of all, I would like to thank you for being here online. It's not something very common for me. I'm used more to traveling and meeting the real audience and discussing with you and sharing our thoughts and ideas on this concept that we developed over 13 years ago. Basically, it was a concept of minimally invasive surgery and implant dentistry that I learned from Dr. Gerb Taffet from Germany, and we developed in a parallel team in Team Bucharest for these 13 years, different thoughts and ideas about minimally invasive approaches. Having this period of our lives that we just hope to finish somehow or go back to some sort of normality soon, we took the chance to organize this webinar and to, let's say, insist about the things and the advantages that this type of minimally invasive surgery can help in the near future, because unfortunately we will have to change a little bit our way of working. And having these ideas in mind, we can adapt both with our, let's say, equipments and technologies for protecting ourselves and protecting our patients, and also for some maneuvers that we can use and remain precise and do our work, not as just some emergency treatments, just do our work in a regular basis, but protecting more ourselves and our patients. So this is why I will start a little bit, first of all, to show you our city, Bucharest, that it was quite empty in the last months or so. And I hope that for people who never came to Bucharest will just enjoy a little bit these images. I have a very nice team. We are almost 30 people in our team in 2 offices. Most of them are now in total lockdown, as we are not able to work. I mean, it was an official military law enforced that dentistry was closed in Romania. Even so, one of our offices received an official approval for treating emergencies from our patients. But in our everyday life, we used to be very happy, socializing. It will be very difficult for people like the Romanians to keep this 2 meters distance in the near future, but we'll see and hope that we will be back to normal someday. Now, one of our main problems in these days are the aerosols. And I found this very nice and interesting article on LinkedIn. So if you just make a print screen and search it afterwards, it's really worth reading it. And it's all about what's going to happen to our professional life after all this, let's say, pandemic things are going to stop, and are we going to be back to some normality in our profession soon? This is part of our one of our offices that was transformed, let's say, to receive 1 or 2 patients per day with a 4 hours break in between patients. And the question is, are we going to need new gadgets for disinfection? In Romania, it's a big fashion with this air nebulizer and also other gadgets that might help, let's say, avoid the cross-contamination. We don't know yet the reality. We will just follow the instructions and then hope that epidemiologists will find the right solution for the dental offices. We also have a very, let's say, strict and safe online form that the patient receives a link and it's going to fulfill all the things about his health. And we also do this rapid test if we decide to see a patient for emergency. So it's very strict, annoying, but we need to do our best to serve our patients if they are in real need of an emergency. Now, of course, there are forms of protest. On the left side, maybe everybody knows already the form of protest in France. In Romania, my colleagues have some other things under the gear. So unfortunately, they are not in the same, let's say, transparency like the French people. Now, going back to our discussion today, we need to think about simple solution for implant patients. For the moment, we are not able to treat these patients. In our country, an emergency, it's limited to some very, very strict maneuvers that can be done. But we hope, as in the next couple of weeks, to be able to go back to our, partially at least, to our normal work. And try to find and figure out how we are going to treat this patient, because our niche, it's the implant dentistry. So basically, this is our main profession, to place implants and do total rehabilitations on implants, and we need to find a good protocol for these patients to be able to treat them in the future when they are going to allow us. So a patient selection will be very important. Either online form scheduling and everything will be very strict. We need to have very good and special access rules. The case should be prepared in advance. Everything should be prepared in advance in the office that the maneuver is going to take place. The protection equipment and different other technologies will be used. Probably each country will recommend different things. But it's very important to have a minimal time during the operation, which is going to be reflected in a less stress for the patient and definitely less stress for the team. And for this type of minimally invasive approaches, aerosol generation is limited to a minimal level, and trying to keep the same maximum precision with our, let's say, digital approach that we do nowadays. Another very, very good article, it's this one. Also, I suggest you should print screen and take a look on that when you open your offices. Now, what is our treatment approach? We respect the minimally invasive approach. We avoid the aerosols, and this way we are going to protect the team and the patient. But we will do, in the end, the same, let's say, treatment. We will follow the same treatment plan. And this is my recommendation. Whenever possible, we can switch on minimally invasive treatments. For our implant strategy in the last 13 years, we tried to do all the time was possible a flapless approach for implant. The biological drilling, it's again one very good advantage in this non-aerosol generation, because we use, you'll see the details, we are going to use the drilling in a special, in a certain manner that we are not going to need water. The backward planning, either digital or analog, will help us, let's say, minimize the treatment time and go just straightforward with a case when we receive the patient after all these protocols. So we are going to talk about flapless implant placement, which is something that is not new. It's from since the beginning of implantology, but there were many years that this was considered very dangerous, because basically you couldn't see the crest. Then in this case, it was for an unexperienced doctor, it was very, let's say, possible to have to do a mistake. But in the last years, having all these digital strategies that are very affordable now and everybody can use in office digital planning, this, let's say, disadvantage of flapless was cancelled. So this is the difference that we discovered 13 years ago. And we decided to go in this manner that we learned from, as I said, from Dr. Taffet. So I'm going to start with a case. It's an older case. Of course, it was done analog way, free-handed. And now you are going to see the difference between doing the cases in an analog way and in a digital way. Nevertheless, even when we did in an analog way, the position of the implant was, let's say, prepared before on the wax up. So we knew exactly when the crown was about to be, and then we decided where to make this punch. and where to place the implant. Of course, with a digital, in the digital world, everything is much more precise now. Now, regarding the advantages, it's post-operative pain and swelling are much more, let's say, developed in a flap procedure. Even the flap is very, very small and tiny. We had some research of ourselves, and we discovered that the advantages of the flapless approach, it's also shown in the cells that are generated around the healing zone. So I will be able to send links to our own researchers afterwards if needed. And we had some very, let's say, straight results found in this regard. Now, the biological drilling. This is something that we learned from Professor Eduardo Anitua from Spain. It's about using the drilling concept of 100 rotations per minute without setting. And it's very good for a flapless approach because it's very slow and you can just go exactly in the right position. And also it's very good for nowadays scope that we are not generating aerosols. Also, another very good advantage is that we can take some of the autologous bone when we take out the drill from the site. So it's an adaptation of the drilling protocol to the biological quality of the bone, which is aerosolless, we named it. And it's 100 rotations per minute, no irrigation. Going back to the case, you can see at that time we had different pins that we were able to use to verify the positioning, the parallelism. These pins were included in the kits. I think they are still in the kits, but now with a digital approach, of course, we don't need to do this. If we trust, of course, if we trust ourselves. So going back to the case, the patient had this fracture. We had to take out the tooth. We used that socket preservation technique of ours called open healing. I will tell you some words about it later. And yes?
Quick question from Gregor McIntosh.
Yes.
Hi, would Alex Ionescu drill still be required, a lens drill? Would you still use a lens drill, or
yes, I understand. Yeah, if there is a thick cortical, then we use the lens. If its bone is not so dense, then we can just go with the first drill. But we go through the cortical, we go with the lens. Now we go guided. You'll see in the next steps. And so then, yes, but when we use it, we use it with high rotation and irrigation. So the first lens drill, it's used with high rotation and irrigation. Now we are going to try to avoid these irrigations for the reasons that we know now. But the official protocol that we do is with first lens drill with irrigation and at least 650 rotations per minute.
One more question before I let you go ahead is from Joel Telles. Hi, Joel, good friend of us from Portugal. Using the bone from the drilling will not implicate higher risks if you use the bone from the drill.
If it's an active bone, we use it. I mean, it's the same. If we can open the Pandora box and discuss about this for 3 days. There is no real risk of contamination through the punch. So we have the punch. The diameter of the punch is a little higher than the diameter of the drill, And if we are not trembling, then we just take out the drill with the bone without touching it to the soft tissue that was taken out from the punch.
Okay, then there's just from Matt Whittingham. One last question regarding the collected bone. Sorry, what reason would we save the bone from the drill if the procedure is a flapless procedure?
When we do, for example, in the same session, maybe four implants, and in one case we need to just open a small flap and complete like a ½ millimeter of bone or something like that. I mean, we save it for different things. For this straightforward case, of course, we don't need it. But I just took the picture to show that if we need to have some autologous bone, we can save it in this way.
Okay, go ahead. There's more questions popping in, but I try to.
Good. Okay, now this is the situation from where we started, and after the open healing, and here 2 years after loading. Now, just a few words about the open healing. It's a procedure after you extract tooth and there is no flap, just some biomaterial inside the socket and covered by a membrane, and then it's a continuous suture, and that's it, without tension. It's coming from the ice cream cone technique of Dennis Tarnow, and I will have some sketches that are going to show the exact way of doing it. So going back to the case, this is after 2 years. The advantages with tissue level implants that the crowns were cemented at the juxtagingival, so there is no risk of cement, and all the time there is, let's say, tendency of papilla formation, having the 5 millimeters maximum distance between the contact point of the crown to adjacent teeth to the bone. And this is a 5 years follow-up, and you see the interproximal stability of the crowns. At that time, the full zirconia crowns were not so nice, just a little bit painted. And this is a CBCT after 5 years, and you can see the stability of the bone around the implants. And here a detail, again with a 5 millimeter rule of the contact point from the up to the bone. And this is one of the last patients that we saw before we were closed down. You see it's in March, a 6 years follow-up, and then a panoramic X-ray. And again, the situation is very stable. It's in a series of patients that we implanted the 3 octa in the first year after the 3 octa was launched. So that is why it's a 6 years follow-up. Now, regarding the flapless procedure, we need to take care of the periosteum. It's very important for us to respect the periosteum and his, let's say, multipotent mesenchymal progenitor cells capacity, and also the fact that it has the potential of enhancing the bone repair. Or whenever we can, we don't cut the periosteum, we don't raise the flap. Of course, when we need to do this, we do it, and we try to be very, very minimally invasive even we do so. So we consider that periosteum is a key factor in regenerating the new bone, and even the bone is very, very thin, and if we go flapless, we have up to 13 years follow-up cases that we still have the bone on the position. Now, going back to our biological concept, we are very, let's say, good friends of tissue level implant. I use tissue level implant for the last 13 years with no exception, regardless where it's placed in an anterior zone or a posterior zone. And we also had our own comparative stress analysis article that was published last year, and we compared two implants, identical implants, tissue level and bone level, and the stress that was generated around the cortical, around the neck of the implant, and around the bone that was exactly immediately after the cortical, so in the marrow bone beneath the cortical. So we had slight differences, of course, doing with the right protocol with the bone level. Maybe statistically it's not a difference, but for us it showed that we had very good results and a stable compression around the implant. So the test was done with a trio of the implant. Now I'm going to show you a comparison between an old case and a new case that we did with another type of tissue level implant. So at that time we used WhatsApp and centered the inner part of the mock-up of these tooth, and then we centered the drilling exactly in that middle of the hole to be sure that we respected the positioning. Now with a digital approach, we do it just through the guide, and I tried to find a similar case from 2011 and 2019 that we did in two ways, analog and digital, and in the same position of the tooth, and this is how we did it before. It's our first approach at the beginning of last year with digital. Now we switched to another software and we do it different. I'm going to show you, but this was a very simple way to do it and use all our let's say tissue level implants that we could use for this type of situations. And Alex, this is how, yeah.
There's one question regarding punch visits. That's why I'm just asking you right now from Bilal Shai. While using the punch, what pre-surgical planning and care is taken to preserve keratinized gingiva, especially on the buccal side?
So if you saw on that on these cases that we showed, there was keratinized gingiva all around. So if we use like a 4 millimeters diameter implant, then we go with a a little bit 3.7 millimeter diameter punch. And if the crest is large enough, then we really don't stress the keratinized gingiva. You are going to see in one of the next cases what we do when it's a narrow crest and we need to let's say do a flapless bone split, and how we preserve the keratinized gingiva. But for these straightforward cases where the crest is wide enough, we don't need to worry because the punch is just the diameter of the implant, and we are not affecting the overall biology. Of course, in some particular cases, we can, I mean, there are many ways to do it with a small incision and then a small roll to the buccal side, but we do this only when it's necessary. Otherwise, we just use the punches safer, quicker, and risk-free.
Okay, then there's one question. What software do you use for implant planning?
What? Sorry, one more.
Which software do you use for implant planning?
Now, here in this case, it's an older case. You can see it's called Blue Sky Bio, but now we use the implant studio from TreeShape, and you are going to see a full case with TreeShape. And even this was a very good and free software. So we did many cases and we were happy. The accuracy that we get now with full integration of TreeShape and Implant Studio, it's much higher. So we now use the TreeShape software. Now I go forward with the planning and the X-rays of 2011 freehand and 2019 digital guide. You can see there is a BIOS. So we had the open healing maneuver both patients with BIOS, and you see here it's a BIOS from our open healing procedure in both cases, and you see that the implant is somehow in the middle of the septum. And now this is our new case after crown cementation, and this is how it looked back in 2011, the first case, and how the first case looked after 8 years. You can see there is no inflammation, the papilla is there, everything is 100% stable. And a CVCT of the 8 years old case. Of course, in the digital world, we were at least the same, we had at least the same precision. Now, going to the next topic, it's a next topic, but with the same concept of approach, with a flapless approach. Immediate implant placement versus delayed implant placement. This is the original, let's say, ice cream cone technique article that we moved and developed our open healing concept. This is one of the articles that was published by Dr. Taffet about the open healing. And this is another article that it was published by me and my team about the open healing and the use of biomaterials. So the best result was obtained with BIOS and BioGuide and with PRGF growing factors when we had the full four surrounding walls around the socket. And also, why do we use our, let's say, 3-octa tissue level implants? We did our research in the satisfaction of the patient, and we had a very good positive result. And also, we did a research on more than 354 patients with tissue level implants from 3-octa, and this is a success and survival rate that is shown here. So it's a quick design of our, let's say, concept. So whenever we extract and it's possible, we implant. And if there is just a small gap, we either do or do not use the membrane. We can fulfill with granules or leave it as it is. But if there is no bone on the buccal bone, then we need to use the membrane in a manner that we use in a ice cream cone technique, and then without any tension, no flap, nothing, just cover it with a membrane and PTFE suture, continuous suture. And when it's not possible to implant, then we use the membrane, we put the membrane inside the alveoli, as you see here in the picture. So we do not take the periosteum out here, so we do not insert the membrane in between the bone and the periosteum. And then we press with the bone granules and we do the pressure on the membrane, then it's this way it's kept there. And then we just close with a continuous suture. Again, no flap, no tension. And this is the procedure in a few words, when you make the implant and when you don't place the implant. This is a old case, so it's possible that some of you already saw it, but all the time with this case I showed, it was a different ending. It's like in a movie when you have different endings to that movie, because this is a patient who is a fan of a soccer team, and he is meeting his friends and counterparts sometimes in the street, and sometimes they meet and sometimes they fight. And as they fight very often now with this restriction, they will not going to fight any longer. But we had a story with this case that started some years ago. So at the beginning, we had this central incisor that it was fractured and we need to take it out. And of course, as the patient did not come immediately, it was a bone resorption, total bone resorption of buccal plate. So we used the procedure that I showed in the sketches before. We introduced the membrane up to the basal bone, and then compression of the bio-os that we fixed that membrane. This is how it looks after we close it. So there is no flap, no tension, and this is the final result after surgery. Again, it's a very patient friendly. The patient will never swallow, will never be hurt about our maneuvers. The provisional that we use the existing tooth that we adhese it with addition teeth. We use a rubber dam to protect the BioGuide, and this is how it looks after 6 months of the healing. Of course, we had to redo the crown here and to rely on biology to recreate the papilla. The implant insertion is, of course, flapless, and we try to just put the implant in the right 3D position. And then with the tissue level, we go with the crown, in the aesthetic zone, we go with the crown directly on the implant. We respect this 5 millimeters contact point rule. Here is a superposition of that, and this is the evolution. Yes, please.
There is a question, I guess, from Germany, from Susan Hoffmann. Which membrane, I have to translate in English, which membrane
BioGuide
used if the bone loss is buccally?
It can be used, a BioGuide, it's one of the membrane, and socket repair, it's the one that originally was recommended by Dennis Tarnow. With BioGuide, you can just adapt it and cut it exactly on your needs, and with a socket repair, it's, let's say, pre-cut with this ice cream cone shape. Well, but I tried other membranes, and I would not recommend any other membrane. So with BioGuide, we are 100% sure that it's staying there for 2-3 weeks until it's going to be secondary healed, and it's the same with socket repair.
Okay, thank you.
Good. So the case was doing well from 2015 to 2018. And before a very big congress, late 2018, I was called by the patient to be notified that there is a problem. I was about to call him myself for a follow-up picture for our presentations, but he told me that he had another fight and something is moving, and now he called me immediately because he didn't want to lose his bone again, and maybe we can say something. Of course, I just hoped at that time that not our implant was broken, but the other tooth, other central, because in this case we were able to show nice outcome for 2 additional implants in the aesthetic zone. And this is a picture just before his fight. So this is our 2018 surprise. The benefit was that we were able to immediately place the implant compared to the other one. So we did it immediately, and this was the result. Here is when we mounted the abutment. For this type of cases, we use these solid abutments that probably everybody knows from tissue level implants, and this is the outcome. Now we had a problem. We were trying to deal with the shape of the crown, and the patient was not so happy with this shape. This is exactly immediately after we made the cementation, so we did not have time to allow the soft tissue to recover. And he was talking to me and said, okay, it's very nice, but it could be better. And then we said, unfortunately, this is our, let's say, best outcome, but we might think of another solution in the near future. This is our CBCT from first part of the case. You can see the bone was up to here, and this is how we reconstructed with the BIOS, and this is after implant placement, and this is at the follow-up. You see the position of the bone is all the time in the same place, especially that everything was done flapless, and this is exactly the opposite with immediate implant placement, the gap that we left just like that, and the situation that remained pretty much the same, even we did not fulfill the gap just with some granules. And in 2018, we came up with this idea, okay, let's take out the crown and make a digital impression, and then replicate the right side to the left side and see how we can solve the problem and have a identical tooth. And then we did it in a digital way. We replicate, and we decided to make a non-prepped veneer of the mesial part of the lateral incisor. So this was our last, let's say, meeting with the patient last November, when we put here the veneer and the crown that we did digitally, and now he is very happy because it's the same shape, same design, and we are also even happier with this digital approach. So this is how it was immediately after we cemented the first crown on this, and then we said, okay, we cut it, and then we do it in a digital way and replicate the other one. And here you can see an X-ray. Here it's a ceramic over zirconia. Okay, and here it's just full zirconia that was copied in a digital manner, and as I said, a minimal prep veneer.
Just because it's the final of this case, and there was this X-ray, there was one question from the first implant you placed with this broken root. Did you do an immediate placement as well, or did you?
No.
First,
no, it was the socket preservation with open healing for 6 months, and then after 6 months it was a flapless implant placement.
And then there's a question from Yusuf Al-Mahaimi, placing the membrane between the periosteum and bone in flapless, is it not, I think it wants to ask, is it not more difficult than raising a flap?
We don't, I said, we are not placing the membrane between the bone and the periosteum. We just insert the membrane inside the alveolar. So it's not difficult. Everything, every difficulty needs to be taken if you can do something without raising the flap. Even if it's very difficult, when it's possible, we don't raise the flap. It's better for the case. Now, a very severe case. As you can see, the crest here, it was a very atrophic case, and we decided with the patient that we are not going to place an implant because it's too complicated for a minimally invasive way. She had some previous conditions that did not allow her, and she didn't want to do massive augmentations for this. She had some orthodontic treatment, and that is why you can see here there is some shadow around the root of the premolar. So we decided to just not do an implant, but to increase a little bit the volume of the soft tissue with the fibroguide, and try to increase the keratinized tissue and the volume of the crest, such as the pontic will be able to be cleaned better in the future. Then this is the healing of the first minimally invasive intervention with a fibroguide. Everything went very well, and we had some more volume there. And the patient came after 6 months, and we were about to do a slight remodeling and then make an impression and do a minimally invasive pontic there. But the patient said, I have decided that I need an implant. And I said, look, we just created all this strategy. We did this surgery to increase the soft tissue volume. Now it's complicated to go back like we never did something and to place an implant. And she said, no, I want the implant. I'm very, I'm decided, and we don't have anything else to do about this. So we decided to do a minimally invasive crest expansion of the flap of the crest with a piezo surgery. Of course, we can do it in another ways, but at that time, with aerosol permissions, piezo surgery was one of our main, let's say, instrument to use in the office. So the crest was slightly enlarged, and it's the same concept that you saw with the open healing technique, and we were able to straighten a little bit that C-shaped crest. And I told her that we are not going to promise you anything because we had these previous conditions that did not allow us to do any extensive surgery. So everything that we were allowed to do was minimally invasive. So that's why we kept in this, let's say, region. Then after 6 months, we created a surgical guide and we started to do, let's say, the drilling procedure. At that time, we used these drills that were universal for all our type of implants. And this is what we got. And it's a very, very big, good stability with the mesh, with the ostel, and the positioning of the implant was exactly the one that we wanted. And this is where we started. You can see it was a very, very narrow crest, and this is the final result. Now, the prosthetic part, we did not care about this because it's a pink neck and it was not visible. And I told the patient that this will be the outcome, and she agreed with that. There are some procedures that we do, but this type of procedure I only explain in the hands-on sessions how we do to cover this problem when needed. So this is the final result, and this is the crown after cementation. And now we go to the x-rays again. So this is where we started. So you can see it was almost impossible to think about an implant in the initial situation. With a C shape, only 8 millimeters up to the nerve and less than 4 millimeter in the thickest part of this crest. And this is after our minimally invasive split with piezo surgery. And this is right here, the 3-octa implant of 8 millimeters. And you can see how the crest was enlarged. So we obtained
diameter 3.7.
Yes, it's a 3.7 per 8, but the patient was very well balanced in terms of dynamics and statics in occlusion. So we said that it's her only option with implants anyways in this case. Okay. That's why I said I didn't promise anything. So this is how we started, a flapless bone split and the implant. So it was no way to, let's say, to be in another position like the one that we got. So it was no room to have any mistake in terms of microns, let's say. And this is the situation where we started, and now after 1 year, it's still stable, and the CBCT follow-up after 1 year. And here you can nicely see how we splitted the crest in this point. I stopped. Maybe you have some questions.
There was just a question from David Chan, and I just wanted to ask him privately that the pink color code of the tissue level implant was darker in this specific case, and the tissue was lighter than the pink color, but it's anyways a much more aesthetic outcome than a gray implant, and the tissue colors are always different, and it just like wanted to know.
No, and it's also there are discussions about it. First, of course, it's not possible to obtain the same color of the tissue. Never. It's just that you improve a little bit the transparency of the neck with the pink colored neck of the tissue level implant. But for this type of cases that you are very, very limited from different reasons of the patients, and you insist to go with a minimal invasive way with a tissue level implant, because the bone level implant in this case would have been destroyed the case, because you know all the things that can happen around the bone level implant to do an extended surgery in this type of case. But we did not care so much about the fact that the color of the pink color of the implant neck was a little bit different from the patient's gingiva in the posterior, and she had a very small mouth. It was not visible. Even she was retracting herself. It was complicated to see. But also there is another thing, that we do some pictures with bouncers when we want to see the texture of the soft tissue or whatever, and then the color is different. Some pictures we do just with a ring flash, and some pictures we do just with the two satellites. And sometimes, unfortunately, there might be possible that one picture was taken with one flash, one picture was taken. Even I have the protocols, but sometimes we are very attentive on the picture, and we maybe not use the same flash just for the presentation reason, to make sure that we show the same luminosity, the same texture in a presentation, because otherwise we take pictures just to see what let's say evolution was.
Okay, then it's just like regarding this pink color coding, as I showed really in the entrance of the presentation, we made a big test to get exactly the color which is the most efficiency. We did a big test with the University in Zurich for that. Maybe we can explain this at the end of the presentation a little bit more detail. One question I want to pass from the smaller case just now is, why didn't you use a bone level? Tracy was asking this, why didn't you use a bone level instead of a tissue level to avoid the showing of the metal part?
I don't trust, as I said. I just use tissue level implants for biological reasons, and I have different clinical studies that I done about this. And as I said, in 13 years, we only used tissue level implants with a very high success rate, and for biological reasons. And I don't want to change the winning team.
Okay.
I don't say it's not possible, but in my hands, it's working with the tissue level implants. In other people's hands, might have worked better in bone level implant. In this type of crest and severity of the atrophy, doing it with no in between components, because as you know, a tissue level implants, it's one piece, so there is no component in between the implant and the abutment, so there is no additional risk at that level. So we just wanted to be safe in this case.
Okay.
And from in our let's say rules, it's a success case. Of course, people might say that it was not a very nice case because it's a collar neck that is visible, but
there's more questions popping in regarding tissue level, bone level. One last question before we continue from Aziz Buni. Did you place any xenograft in the middle of the splitted alveolar bone? And if yes, how did you place the BioGuide?
Yes, I placed, and then the BioGuide was just put over. I mean, it was just covering, and then it remained a small gap that was covered by BioGuide, as you saw in the picture. So it was not inserted in between the soft tissue and the bone or something, just like just a cover.
I think, as I see
it was a very small gap, and in these cases we just put the BioGuide. We cut it very, very tiny, and with no stress. If I can go back if you want with a picture.
Yeah. Okay, all the other questions regarding bone and tissue level, I try to pass to Alex in the end of our presentation. And so please go ahead, Alex.
Okay, so just to show picture here is it's just like a cover. It's a small rectangle oval, let's say, that was covered the split. It was like a small split like that, covered with this. Okay, let me go back. We still have 2 cases, the digital one and the last similar one with the one that you saw, but that we used some digital approach. Again, the membrane, now it's very obvious how we cut it. It's the same concept, the same procedure, but this case didn't go as nice as the other one in terms of healing. And you can see we had a bone resorption here. I don't want to blame on the patient or on other things, but that's why I tried to select a case that had the worst outcome that was possible in our office. And then you can see how we handle the worst outcome case. So this is the worst outcome case that it happened in 13 years. And then we decided to enhance a little bit this gap here, marked with a yellow arrow. So for this, we have different approaches, and the most minimally invasive approach is to enlarge the bone from the inside and still remain flapless. So this is the original concept that was presented in 2014, and based on that, replacing the osteotomes with a piezo surgery and then going back in the end with the osteotom, we did this somehow guided. So we marked our place of the implant, then we entered with a piezo tips and then with the osteotom. So basically, without touching the surrounding soft tissue, we obtained this result. Of course, for these cases, if we consider that result is not enough in terms of let's say aesthetic satisfaction, we can all the time do any other. Sorry, can you hear me? Yeah, I think that Siri thought that I was talking to her. Sorry. Good. So in these flapless cases, we can do anytime we want an additional soft tissue surgery, because basically we never touched that particular zone. So it's like just we never did something before, but usually we don't, we are not in need for that. So this is the situation after the implant placement. As you can see, after 6 months before loading, it was a very big gap here with a fistula that you saw, and this is how it was healed and the level of the bone up to here. So this was prosthetics. This is how we have the color with this special digital approach, and this is the before and after the treatment. And we were supposed to see the patient this year, but with a lockdown, this is the only picture that we have after we finish the case and make the cementation. And this is the X-ray where we started and with the final crown. It's and that's why I wanted to show this case. Even the outcome after the socket preservation was not so nice. In the end, we were not in need of any additional surgery. We just expanded crest from the inside in again in a flapless approach. Now we go back to the last topic and the last case, straightforward case that was done with a new, let's say, digital approach with the 3Shape software that we discussed at the beginning. I think we are fine with the timing. Before that, this is maybe the largest aesthetic, dental aesthetic online congress that is going to be this year. We had the largest congress in it. I'm part of the board, that's why I'm telling you about it. We had the largest congress in Eastern Europe, the real congress with people meeting each other. Now we moved, instead of canceling, we discussed with all the speakers and everybody agreed to keep the same schedule and do it online, everybody in his own lockdown. Now there is a new hope and a new idea from TRI. I think it's most interesting ideas of going to digital in the implant dentistry. It's still a project that is not, let's say, officially revealed. It's the name of the project is Matrix. It's a first digital implant, and I'm very keen. I was supposed to try it probably maybe today or last days, but because of the lockdown, everything was postponed for the moment. And I hope Holger will be able to give you a little information about that in the end. Now, the existing digital protocol that it's available for the moment, I'm going to show you a straightforward case, not 100% straightforward, but here is the case. So a quite narrow crest that needed an implant with a minimally invasive approach. The CBCT that you can see before and after, and this is kind of going to show you how we got there. We started with a prosthetic planning. We used for this planning only this software. So the prosthetic planning, then we put the CBCT information in the prosthetic in the Implant Studio software. And then here are the 3 points alignment. So basically what we do, we align the scanning, the intraoral scan with a CBCT. It's a very, let's say, intuitive software. I mean, even I'm not very good. I'm not very bad in IT. For me, it was like after the first case, I said, wow, this is very precise and very easy. And for the moment, TRI has the possibility to go digital with the existing implants with the first drill. So there is a sleeve for the first drill. So we use it like that. It's like partially guided, and the last drill, it's usually done freehand because we still wait for these sleeves to be available. And this is the positioning of the implant, how we planned it, and how we created the guide. With this software, I am not a very good IT guy. So with this software, it takes me less than 10 minutes to generate the guide and then send it to the printer. So it's cost effective and it's very fast. Then we just print it and put the sleeve that we get from TRI, and we just go from the planning to the final result in a very precise way. I suggest everybody who did not start with the digital treatment, or it's about to start with digital treatments in implant, should make his own planning. I mean, it's one to do it yourself, to know exactly where you planned, and then to plan it with your own mind, eyes, and hand on the mouse, compared to sending the information to any other, let's say, specialist who can help you with generating the guide and positioning the implant. Even you describe that you want to position in this particular point. So I suggest that it's something that we should do ourselves, and also the prosthetics should be very well understood in terms of static and dynamic stability. And this is how we enlarged, minimally invasive. You'll see the clinical pictures, and we have bone around the implant, and we did this guided, and it was guided with surgical guide and with a Versa drills that we use in this type of cases, that there is a very small incision, and then we enlarge the crest just with a Versa but it's a very, very nice concept. And sometimes now that we are not going to be able to use piezosurgery in the near future, this is a very good concept of non-generating aerosols in our everyday minimal invasive practice. And now a little bit of the technical work, that there is a very nice, let's say, multi-usable titanium abutment from TRI. Then the concept of the tooth that was originally designed, and final result. We printed the models. It was possible even not to print the models, but we printed just to make sure that I double check, as I'm 20 years in this prosthetic business, and I'm only 1 year in the digital world. So I just want to make sure that I understand the things that I do and double check them. And this is the false gingiva that was here, and the contact point that was measured 5 millimeters from the contact point to the bone. This is the information that is now very easy to be transmitted to the laboratory. And this is how the crest looked, and with that small incision, and you see that there is no loss of keratinized tissue here, and the stability of the TRI implant is 84. With Austerity, you saw that it's a much better stability than you saw with other very well-known implant that I show in one of my cases before. And this is the final result. And the X-ray. And at that time, when we started last year with the digital, we just hoped that the digital will not, the robots will not start to rule us. And then it was a very, let's say, interesting comparison between the humans controlling the situation and the robots controlling our brain. And when everybody was so afraid about this, then something else came and stopped our inner problems, and at least we need to take the benefit of this lockdown, that at least that we have a month or so of stopping ourselves. I mean, I was trying to get a break somehow, and I never found the time, never. And then just we were forced, and we had time to think about different things. Now we think to how to go back to normal. Now, after 13 years of minimally invasive, flapless, open healing, tissue level implants, and biological concept, we obtained a very good patient comfort, and also we had a very good team comfort for this period. And of course, now we introduce this aerosolless. But in the end of the day, the problem is that we need to find alternative treatment concepts that will help us do our work with the best outcomes, without being afraid of having another contamination problem or whatever, until this will come to an end, even if it's good and bad and true and false, and we don't know exactly. Until then, we just need to redesign our concepts in our everyday life, and we hope in Romania that in 2 weeks we are going to be able to open all the offices, not only a few offices, and start doing some very, very safe and good procedure, in our case, in a minimal invasive way. So this is my email address. If any one of you just want to contact me, either on Facebook or on my email address regarding anything that I know about minimally invasive approach that we studied for the last 13 years, I will definitely come back with an answer. Thank you.
Thank you, Alex, so far. I have a lot of questions. I'm very sure we cannot answer all the questions. We try to pass the questions we couldn't answer at the end to Alex after this presentation and send them via email to you. But I know that we are doing a big study with you, and because there was the question from Peter very in the beginning of the presentation, and he was asking, is the success rate affected by this biological drilling protocol good for immediate placements. And I think the study which we do will show a very high success rate over the years we are working together. But maybe you can talk a little bit about success rates and so far.
So regarding the biological drilling, as we did all the cases with the biological drilling, it's not one of the let's say quantifiable ideas that we are going to show in the study. So we did not have a control group with a classical drilling versus biological drilling, because this was already done by Professor Anitua, and I just saw him and his concept in 2014 and considered that it was a good idea, and then introduced it and improved our everyday, let's say, clinical result. But in a research, let's say, guidance, we did not include. We used for all the implant placement, it was the same concept of biological drilling, so it will not be shown in the result. Now, regarding the success rate and the survival rate, I think there, when we are going to be able to publish all the results, will be more than 450 implants, and at this moment, the preliminary results, we have like a 97.8 success rate and 98.5 survival rate. So considering that I included any small problem like pain or whatever small reaction in minimizing the success rate, that's why it's there. It's less than 2% with a survival rate. It's very good. I mean, this is in our hand. But all the cases were done with a flapless approach, with either immediate implant placement or flapless late delayed implant placement. So no flap in the case. We only had the 20 cases control group with a small flap with the biomarkers that I told you about in the beginning.
Leads to two questions of Yusuf. One was from the very beginning, but before you answer, let me ask both questions. One is just to clarify, did you treat all the conditions, even those need bone augmentation vertical and horizontal way, by flapless techniques? And he asked very at the beginning, is a drilling irrigation with type 1 bone needed with this protocol, protocol you described, or maybe you can answer these two questions of yours.
Okay, first question. We included in the study the cases that were possible to be done in a flapless manner. So it was not all the cases that we done in 5 years, just the cases that we selected to be included. And these cases were the ones that we were able to do in a flapless manner. Now, regarding the, I lost your the visuals. Can you hear me?
Yes, yeah, we can hear you. I just made myself to moderate. You do
okay.
You flash marks, I think. Yeah.
Okay, good. Can you repeat the second question, please?
The second question was irrigation of.
Irrigation, yes. So the biological drilling can be done in the type 1 bone, and if there is a lot of cortical, very dense, even we go with 100 rotation per minute, then we do a little irrigation. So we do with the same low speed, but we do a little irrigation if there is very, very dense type 1.
One more question from Mark Edmondson. He's asking, what is the healing time for an ice cream or ice cone technique membrane to repair the buccal wall with BIOS?
Our standard timing is 6 months.
Okay. Then I think for now, I think that's the questions, interesting questions. We will go through all the questions after these presentations, and if there's questions I forgot to ask Alex during his presentation, please, I'm sorry, but we can pass them to Alex, and he can answer them via email later on. Thank you very much, Alex, for a great presentation. I just want to take a few minutes or a few seconds, actually, to just repeat what you said. TRI is working on the first digital implant, and this digital implant is going to be a revolutionary new way of creating prosthetic on top of implants, and it's a fully digital workflow. And I think in the next couple of weeks, or months, we're going to have some more webinars. For example, the webinar with Professor Fanze, who is having this webinar on the 15th of May at the same time, 11 o'clock Central European time. Who is explaining a lot about new materials which you use with the digital workflows, which are very important for digital workflows, new materials you can use in the patient's mouth for prosthetics. And please stay tuned and sign up for the next webinar with Professor Dr. Konstantin Fanze. Then there is for all Turkish-spoken members here or participants, we're going to have a webinar in Turkish language on the 4th of May with Dr. Sayed Yilmaz, and it's about all-on-4 techniques. It's a Turkish-spoken webinar. Please sign up for this webinar. And last but not least, it's also on my side. Thank you for listening. Thank you, Alex, again for a really great, very great presentation, and hope we can see each other in reality soon after this time. And there was one question I want to just say at the end, if we're going to do a course, and I think when Alex and when it's possible to travel again, we're going to start a new course series with Alecsandru Ionescu in Zurich or in other countries at the beginning of next year. This will come for sure, and I'm looking forward for that. Thank you very much, Alex. Yeah.
Thank you, and thank you everybody for being here and listening to this presentation. And I wish you stay safe and go back to work safe. Thank you.
Bye. Stay tuned.